Chapter 7, Physical Development and Health in Early Childhood. An overview of the chapter, we will cover growth of the body and brain, motor development, children's health and safety, child maltreatment, and neglect. Of all the organs, the brain grows most rapidly between the ages of 2 and 5. Bodily growth does continue, but at a slower pace than in the infant and toddler years, adding an average of 2 to 3 inches in height and 5 pounds in weight about each year. Children begin to lose baby fat and appear taller, slimmer, and more erect. The average girl matures faster than the average boy, with girls having greater fine motor skills. The human brain grows about 80% of its adult volume by age 2 and another 10% between 2 and 6 years of age. Synaptogenesis, pruning, and myelination continue to reshape the brain, particularly in language areas and the prefrontal cortex. Gray matter, where neuron cell bodies, dendrites, and synapses grow rapidly in the first 2 years, begins to slow in pace, and it peaks in late childhood, followed by a decline after age 10. White matter shows rapid increase in infancy, followed by a more gradual increase from age 3 to early adulthood. Biological factors contribute to the development of executive functions, abnormalities in development of prefrontal cortex brain circuits that may result in disorders of genetic or prenatal origin, such as obsessive-compulsive disorder, Tourette syndrome, and attention deficit hyperactivity disorder. Environmental factors such as socioeconomic status and culture may also contribute to differences in executive functions. Early results from the Family Life Project reveal a variety of risk factors in working memory, inhibition, and mental switching at age 3. The strongest predictor of executive functioning is cumulative risk. It is a composite including factors such as family income, marital status, environmental stress, maternal depression, food insufficiency, and health problems within the family. Parenting quality plays a role. Parents with the highest cumulative risks are more likely to be low in positive engagement and less likely to provide books and toys. Parents help shape executive functions by providing structure and organization. Culture may also influence parenting practices, thus impacting the development of executive functions. Executive functions impact school performance as children need to pay attention, inhibit off-task behavior, and remember instructions. How important is recess or playtime for young children's development? And what sorts of activities beyond recess and playtime support the development of motor skills? And we will try to address these questions. By age 2 to 2.5 years, children learn to walk efficiently. Once walking is learned, they begin to develop fundamental movement skills, which include running, hopping, skipping, jumping, throwing, catching, and kicking. Fine motor skills develop, as I said, between ages 2 and 5, and activities such as writing, drawing, and fastening buttons and tying shoelaces develop. As early as 18 months, children learn to hold a pencil or a crayon in a power grip. Practice determines increased dexterity, but by about age 6, they progress to the tripod grip. By age 4, many children can write their own name and produce legible representations of the 26 letters of the alphabet. Evidence suggests that providing correct practice with the pencil beginning at age 2.5 can lead to earlier and more accurate letter writing when children begin school. "85% of infants adopt a position in the womb that makes it easier for right arm movements, which indicates that a tendency toward handedness can begin in the womb. Newborns have a preferred head and arm orientation, either right or left, that correlates with their prenatal orientation. Some infants may switch hand preference after 6 months of age. There's a figure in your textbook, figure 7.8, which is the development of hand preference in infancy, which indicates that hand preferences between 6 and 14 months, we see 38% had a stable right hand preference, 14% a stable left hand preference, and 48% began using either hand but steadily increased preference for right hand. There is brain plasticity for hand preference in the first 2 years of life. Social experience influences handedness, with mothers showing unconscious behaviors indicating bias in movements that stimulate the child's hand preference. At what age do you first remember learning about healthy behaviors? Are children born with the innate ability to discern between healthy food choices and unhealthy food choices? And do children know how to self-regulate their sleep time? This is what we will address in talking about children's health and safety. Toddlers ages 1 to 2 tend to sleep about 12 to 14 hours a day, with one nap of 1 to 3 hours, whereas 3 to 5-year-olds sleep less. Sleep difficulties begin to appear between 2 and 5 years of age. How can parents teach children to make healthy choices? Effective methods include offering children the same food repeatedly. Children tend to prefer what they are exposed to most often. Have you ever experienced this with an initially unfamiliar food within the past few years, for example? Another effective technique involves offering healthy foods in pleasant surroundings. And less than 1% of children in the U.S. are considered malnourished. About 9% of children between 2 and 5 were considered obese, and this is increasing at an alarming rate. Some children may experience food insecurity, irregular servings of nutritious food needed to provide for normal activity and health, with the rate of food insecurity in the U.S. estimated at 10% in the year 2013. Not getting consistent healthy foods is associated with poorer health and school achievement and increased risk of obesity. Health recommendations for young children include regular medical checkups, continued immunizations, and beginning self-care with the teeth. Regular medical checkups require access to affordable medical care, and about 3% of children in the U.S. have no usual source of medical care. Children experience an average of 7 to 10 colds per year, with higher rates in children attending child care centers or preschool. Middle ear infections result in more complications and may create temporary problems with hearing. Although few children die of infectious diseases in the U.S., worldwide the most frequent killer of infants are preterm birth and asphyxia, while pneumonia and diarrhea kill young children most often, followed by malaria and other infections. In the United States and other industrialized countries, accidents are the most common source of injuries or death among children 11 years and younger, and occur more often in children under age 5. Fatal injuries are rare and most commonly involve accidents followed by birth defects and homicide at ages 1 to 4. Children with ADD or hyperactivity are more likely to have physical accidents than other children. Parental instruction in safety rules and parental oversight in the home help reduce rates of injuries and accidental death. Low compliance with parental rules and lack of direct parental supervision are strong predictors of injury rates in 4 to 6-year-olds. Injury and fatality rates are highest among American Indian, Alaska Native, and African American children, and lowest among Asian Pacific Islanders, with white and Hispanic children falling in between. Children may be more vulnerable to the dangers of environmental hazards than adults are because they lack knowledge about how to identify and avoid such dangers. Estimates suggest that 9% of young children are exposed to significant levels of secondhand smoke. Children exposed to secondhand smoke have increased incidence of infections in the lower respiratory tract, bronchitis, pneumonia, middle ear disease, sudden infant death syndrome, and respiratory symptoms. Small amounts of lead in the bloodstream are associated in young children with nervous system damage, deficits on IQ, memory, and problem-solving tests, and attentional and behavioral difficulties that can persist into adulthood. Lead appears to cause permanent harm in the brain and is compounded by poverty and poor diet. About 3% of American children as a whole and 6% of African American children had dangerously high levels of lead in their blood in surveys conducted in 2007 and 2010. How do you interpret the following biblical proverb? Spare the rod and spoil the child. We will learn difference amongst 4 types of maltreatment: physical abuse, emotional, psychological abuse, sexual abuse, and neglect in this section. Maltreatment consists of physical abuse, emotional, psychological abuse, sexual abuse, and neglect that result in death, serious physical or emotional harm, or sexual abuse or exploitation, or create an imminent risk of serious harm. Child Protective Services reported in 2011 that 10 per 1,000 children under 18 were maltreated. In the Child Protective Services data, parents were the source of maltreatment more than 80% of the time. Risk factors for physical abuse: living conditions of poverty, single parenthood, lack of social support, social isolation, history of abuse, history of mental illness or substance use. Children with disabilities are twice as likely to be abused as children without disabilities. Rising stress levels combined with lack of parenting skills present the fuel for abuse. Neglect is more likely to occur with high stress levels. Drug and alcohol abuse is often involved. Emotional abuse is more difficult to study. Sexual abuse is uncommon prior to age 3, but more common for older children and reaches a peak between ages 12 and 15. Sexual abusers are socially isolated, have relationship problems, low self-esteem, and may have psychiatric disorders. The effects of abuse are likely to follow a developmental cascade. The idea behind this concept is that negative events or behavior at one age create negative behavior at subsequent ages. The child's worsening behavior in combination with other factors in the environment can lead to a worsening set of behavior and emotional patterns, even to outright psychological disorder. Physical and emotional abuse may alter the course of early brain development by increasing harmful levels of stress hormone cortisol. MRI scans of maltreated children show evidence of reduced cerebral volume, larger ventricles, and smaller corpus callosum. Children who have a history of physical abuse have deficits in language, IQ, and academic achievement. Maltreated children develop atypical responses to emotional distress in other people. 70 to 90% of maltreated infants have been found to have insecure or disorganized attachments and may have poor emotional regulations. They may act aggressively or withdraw from social interactions with peers. 2 strategies to help prevent maltreatment include minimizing stress and improving mother-child attachment relationships. I would also include father-child attachment relationships in that statement. Minimizing stress includes assisting at-risk families to manage their daily lives and childcare, and interventions that can improve attachment relationships between mothers and maltreated children include attachment building and psychoeducational interventions. If any of you plan on working with children, you would be considered a mandated reporter, meaning that if you suspect at any time a child is being abused or neglected, you have a duty to report this to Child Protective Services. Personally, I've reported several cases to Child Protective Services. I counseled children in elementary schools, and I saw mostly physical abuse in my reporting of children. So just keep in mind that if any of you are working with anyone under the age of 18, whether in a school or a therapeutic setting or even as a coach or anywhere else, you are a mandated reporter and required to report this. Thank you very much, and I look forward to next week.